Hi, everybody. It's Carly. Just was going to record this lecture on pain, temperature regulation, sleep, and sensory function. The lecture mainly focuses on the first three. I did separate out the sensory function, and we will discuss that as we kind of move into neuro and more of the respiratory when we talk about like HEENT, like the head, eyes, ears, nose, and throat. It just was kind of a lot and to put with this section essentially. So I want to focus on the first three for this lecture. So obviously pain, you guys are well aware of pain and have a good foundation in this with your previous practice. But obviously pain is any unpleasant sensory or emotional experience associated with the actual or potential tissue damage or described in terms of such damage. So essentially it's whatever the patient's experiencing or whatever he says it is, or he or she. So the big thing obviously is it's a more subjective experience in terms of how the patient feels about it. So once again, we can't discount pain, and obviously, we have to inquire about this. The neuroanatomy of pain, so we'll discuss this in a little bit more detail, and look at different types of pain and how it's transmitted essentially, and really how it helps you distinguish between the types of different pain. When we look at the term nociception, essentially that just means the perception of pain. We have primary order neurons, so essentially this is how it's transmitted up to the brain. And then obviously it's perceived and then the patient feels pain. So you have primary order neurons, which basically start with the nociceptors. You have nerve endings in your skin, your muscle, joints, arteries, viscera, and they all respond to different chemical mediators, mechanical stressors, thermal or chemical injury. And obviously some areas have more of these nociceptors or nerve endings in certain areas of your body. A good example is like your fingertips. They're much more sensitive to to injury versus like another area. It can detect a wide range of stimuli. There's certain nerve fibers that are more characteristic for that sharp pain versus a more dull, achy pain. So when you hear about sharp pain, that's usually more localized, and it's usually that fast transmission of what they call A delta fibers. So those are the ones that transmit really quick, and it's usually to prompt that acute pain response. For prevention of further injury. Then you have the C fibers, and they're unmyelinated, so it's a little bit more on that side of dull aching pain or a burning pain, and it's kind of poorly localized where, it's completely different than the A. So this is more of that longer lasting dull, chronic achy pain. And then you have second order neurons, and essentially when you look at primary, secondary, third, that's just the level essentially of where this nerve is being transmitted. So secondary is basically the spinal cord up to the thalamus. Your third is where you get from your thalamus to your higher cortical areas like your sensory cortex, your frontal cortex, the limbic system, and that's essentially where the pain is actually perceived, by the brain. This is just an image of it. And as we move into neuro, we'll talk a little bit more about like proprioception, because you'll get into that with health assessment too. But proprioception essentially means like awareness of a body position. It's kind of hard to describe, but we'll talk about when we get into neuro. Right now, I just added this essentially to kind of look at that path of like, okay, you have nociception and you have nerve endings at the peripheral level, and that obviously gets transmitted to your spinal cord, and then it goes back up to your thalamus, to your cortex, essentially. So it was just an example of showing you the primary, secondary, tertiary neurons, essentially. That's the only reason why I added this. The second slide I added this image to kind of put it in perspective of clinical treatment. When you look at pain, once again, it's very complex. There's lots of different types of pain, and once we get into more of those chronic pain syndromes, they're much more difficult to treat. And not that acute pain isn't either, but there's certain, obviously, disease states that are harder to treat than others. This is just a good example to kind of put it in perspective of why understanding that pathophysiology there and how it's transmitted, how it kind of relates to our treatment. And once again, I don't expect you to memorize treatment at this point, but it's just to kind of put it together with a clinical picture. When you have a patient that's in pain, I'll give you an example of, a patient that has lumbar radiculopathy, where they have impingement upon a nerve and they have leg pain. Well, you have these exiting nerve roots that come out of your spinal cord, essentially. Those are considered peripheral nerves, and we actually will talk about this when we get into neuro more. Then you have more of the central nervous system, which is within your cord. Your spinal cord is inclusive to that. And then obviously those nerves that are impulsed up to your brain, You have your medulla, midbrain, cortex. Well, these are just different areas that you can pinpoint or target in terms of treatment. If you look at all the way at the peripheral level, when you look at skin, I mean, things like muscle relaxation, things just like massage, I mean, capsaicin creams, so things that work at that topical level. And then we have anti-inflammatories like NSAIDs that essentially work more at decreasing all those inflammatory mediators at that level. Heat, cold, these are all good examples. Then you kind of move up to those exiting nerve roots. We have like nerve blocks, epidural injections, and that's a little bit closer to the spine. But when you go nerve blocks or even like a TENS unit, we're targeting that exiting nerve root. As you move further up the central nervous system, we use things like tricyclic antidepressants or different types of antidepressants, like amitriptyline is a good example. They show too, like epidurals. Systemic opioids is a big thing, obviously, and that's working at the brain, so that's working higher up at that cortical level. And even things like we talk about in nursing, like music therapy and hypnosis or imagery, guided imagery, those things work at that higher level at the brain. So that's why a lot of times we'll target different areas of treatment in terms of pain management. So I just thought it was a good way to help you understand the process here and how it applies essentially to how, you would institute treatment essentially for, different pain syndromes. Obviously, there's different chemical and neurotransmitters that affect the perception of pain. Sometimes you'll hear about ones that excite the pain response or some that inhibit it. These are more of the common ones. There's multiple ones that obviously impact pain or excite that pain response essentially. But all those inflammatory mediators that we'll talk about in the immune system, like histamine, prostaglandins, tumor necrosis factor, these are all inflammatory mediators that, like histamine, if you think about histamine increases like vascular permeability, they get swelling. Prostaglandins, once again, is heavily integrated in with that inflammatory response. Same thing with like TNF. Substance P and glutamate are another ones that are actually excite pain response. And then we also have ones that inhibit it, like serotonin or GABA or norepinephrine or general endorphins that are naturally produced by the body. Once again, that's exactly why we use different medicines. Like, for instance, a good one that has impact on norepinephrine and serotonin is Cymbalta. So we use it for depression, but it's also indicated for like fibromyalgia, and sometimes it helps with chronic pain. And this is exactly why, because it hits these other receptors. When you get into pharmacology, you'll talk about different opioid receptors because there's 3 typical ones that we tend to target in terms of treatment: the mu, kappa, delta. So depending on the agent that you give, they either hit all of them or 2 of them. But those essentially are ones that inhibit that pain response. So that's why, once again, we use treatments that target these receptors. And once you get into pharma, I think I've already mentioned this, but a lot of pharmacology is based off of our normal physiologic mechanisms. So we have a lot of different receptors that, that these agents work at. And essentially they either, most of the time, kind of turn them on, or they bind to that receptor and facilitate their function essentially. So a lot of patho kind of helps you follow through with pharm. So that's why I try to bring this up in there too. This is just your normal natural endorphin response. I don't expect you to memorize this table or this box, anything in there. I'm just trying to explain to you kind of how it interrelates with that pain inhibition. So obviously you have your afferent pathways and your efferent pathways. We'll talk about this in neuro more, but you have the response that goes up to the brain, and then obviously it gets perceived, and then it gets perceived down that efferent pathway. But your endorphins, and kind of you have these receptors that essentially that these endorphins will bind to, and it blocks that transmission of pain essentially, because those release of endorphins are kind of binding at that receptor. So it's just an example of how it reduces pain transmission on those ascending pathways essentially. When we describe pain, sometimes you'll hear the term pain threshold, and essentially this is kind of patient specific, and there's factors that can affect it, but it's essentially when they can perceive the stimulus as pain. It typically doesn't vary very significantly among people or in that same individual over time. So it's kind of a common factor, obviously, but there can be changes dependent upon other, clinical indications or, other disease states that the patient may have. So another thing, they may have, pain at one location, and it may increase the threshold in another location. They just become hypersensitive to pain, essentially. Another term is perceptual dominance, and this is probably common. You've probably seen this before. An individual with a lot of painful sites may only report the most painful. So you may have a patient that had back surgery, and they have really bad knee arthritis. Well, they may not complain about their knees because their back hurts more. But obviously, after they heal and that back pain relieves or gets relieved, sometimes they start to have more knee pain again. That's just an example. So that's what they call perceptual dominance. And it's because a lot of it's because of the interaction with our brain and our nervous system, essentially. So pain tolerance essentially is when we look at that duration of time or the actual intensity of pain that they will endure before initiating like a pain response. And this is heavily influenced by different factors such as gender, cultural perceptions, expectations, role behaviors, physical and mental health. I think I mentioned it before, but a lot of times chronic pain, if it becomes chronic, unfortunately has a lot of negative outcomes in terms of mental health. Like there's a lot of anxiety and depression that's associated with it. And once again, depression can feed into chronic pain as well. It tends to decrease with repetitive pain, or the pain tolerance, I should say, decreases. So they are more receptible to having pain. If they have fatigue, so if there's less sleep, they may have more pain the next day. Anytime that they have a lot of anxiety or anger, or just general changes in life, they may have exacerbations or further increasing or decreasing in that pain tolerance. Things that help pain tolerance, obviously, are alcohol consumption, which we would never recommend, pain medication, hypnosis, warmth, distracting activities, strong beliefs or faiths. So a lot of these things are very beneficial, besides alcohol, to patients' comfort, essentially. This can vary greatly among people and even in the same person over time. So once again, there's a lot of lifestyle factors that can, exacerbate or, help with pain control. Nociceptive pain, I kind of already mentioned that, but we'll kind of describe it in terms of different areas. So nociceptive is actually pain with normal tissue injuries. So there's an underlying cause there, whether it's chemical, mechanical, etc. But we can further vary this or describe it as somatic or visceral. And I'm sure you remember this from your previous, courses that you've taken. But somatic essentially is looking at a section of the body, whether it's, the trunk of the body, an extremity, the head, the neck. Where visceral is more internal. So that's, an internal organ pain, essentially. So that's, those are the two that you would consider nociceptive. Non-nociceptive is essentially what we would consider neuropathic pain. Neuropathic pain is very hard to treat. Very, very difficult, and it's most often chronic. Peripheral, it can originate from a peripheral issue or a central issue. So a peripheral issue, it's usually from a lesion or lesions that originate from the peripheral nervous system. So anything peripheral is essentially exiting that nerve root out of the spinal cord. Your spinal cord is actually considered central, but any of those nerve roots that come out of there are peripheral. And even the nerves that are in your legs, like you think about diabetic neuropathy, that's a great example. Or you think about nerve impingement from a back again, like if you have a herniated disc, that's peripheral and would be considered neuropathic. Central or central, so that's either your brain or your spinal cord. Those would be things like you might have patients that have dopamine. They might have Parkinson's and they have pain associated with it. Or spinal cord injuries. They still can have pain with that, essentially. On table 16.2, there's just some more descriptors of, the different types of pain. You can take a look at that if it helps too. In terms of acute pain, once again, it's more of a protective mechanism and, it's really to alert the person that there's harm there, essentially. It dissipates, obviously, after the stimulus is removed or the tissue heals. And once again, I'm sure you get this. You have that, you have those acute changes with pain, whether it's tachycardia, hypertension, fever, diaphoresis, dilated pupils. So it's kind of like that sympathetic response that you get, from stress on the body, essentially. Even elevated blood sugars, because remember when we talk about stress and disease, stress on the body can actually elevate your blood sugars levels as well. So once again, with acute pain, obviously it can have negative outcomes on the patient's, blood pressure. So that's why we obviously make sure that we're, treating it appropriately. Acute somatic, so like I said, it's usually more of that axial skeleton or part of the body, whether it's like your connective tissue, muscle, bone, skin, etc. Once again, the A delta fibers are those sharp, well localized. C is more those dull, aching, poorly localized pain receptors. And then when we look at acute visceral, this is once again internal organs, and we commonly refer this to like your abdominal or an abdominal pain, essentially in a patient. And I'm sure you've all experienced this with patients. Sometimes it's very poorly localized, like it's kind of a diffuse pain that they feel in their, internally, and it can be at times referred. So that's very common. A good example is when you think about abdominal pain. It does get transmitted by a lot of these sympathetic nerves, essentially, and that's why a lot of times there's an overlap with, or I shouldn't say overlap. That's why there's actually you get this pattern of referred pain because it kind of crosses, and then other areas, and they start to feel pain, in areas where it's not exactly originating from. It's heavily associated with things like nausea, vomiting, changes in blood pressure, restlessness. Obviously, if it's an underlying significant issue, shock, obviously, if that's like peritonitis or something like that, obviously you worry about that too. In terms of referred pain, I'm sure you know what this means. It's basically pain that's distant from its point of origin. So once again, that referred pain is basically supplied by that same spinal segment as the actual site of pain, essentially. So they may get like converging impulses there, which is why they start to get pain in different areas. Good examples, myocardial infarction. You guys know this. I mean, you can have jaw pain, you can have arm pain, you can have back pain, obviously chest pain. But once again, the presentation of it is not always just in the chest. Same thing, very common with pancreatitis, pancreatic changes. You can have, back pain from that. Renal disease is another one. Huge one that you'll see a lot is kidney stones. So anytime you have kidney stones, sometimes they'll present with lower abdominal pain or they present with flank pain. They can present with groin pain. So a lot of times it can change. Gallbladder is another big one. You always inquire about right upper shoulder pain. They tend to get this very frequently. So not only do they have right upper quadrant abdominal pain, but they also tend to have right shoulder pain with it. Not always, but you inquire about it. And that's just like another key indicator to figuring out what's going on with the patient. This is just an image of those areas that you commonly have referred pain. And I have another one on the next slide. Once again, like your gallbladder can go up to that right upper shoulder. Heart, once again, obviously you pretty much probably know this, but just general areas of your bladder, your kidneys, even you think about like the uterus. A lot of women will have back pain, with menstrual cycles from inflammation of the uterus. So not only lower abdominal pain, but they may have back pain with it too, which is common. It's just essentially because of that pain sensation in that area. I just added these with the male patient on there too, because obviously too you can have, and we actually were just talking about with men and having like kidney stones, for instance, or urinary issues. They can actually have like lower buttock pain because a lot of it's interconnected with your prostate. So sometimes they'll have referred pain in that back area. But once again, these are the same things that I kind of pretty much just went through. And these are the typical areas that you will see referred pain. But the big ones, like I said, is gallbladder. Another good one is appendicitis. You usually have right lower quadrant pain, but it tends to travel up to the periumbilical area. So it's not uncommon for this to occur. Ovaries, sometimes you can have middle abdominal pain. Like if you had a patient with an ovarian cyst, it's not uncommon that they kind of have more of like a generalized abdominal pain. It tends to be lower. It's not high, but they tend to have, it's not exactly where you would expect it all the time. So you just got to be aware of that essentially. In terms of chronic pain, we always define it essentially anything greater than 3 months. So that's kind of like the guideline in terms of when we consider things chronic pain. Unfortunately, there's a lot of complex interactions here with chronic pain. And really, it's kind of a misinterpretation of nociceptive input. So there's a lot of structural changes or neurologic changes, essentially, that occur and can exacerbate chronic pain, essentially. There may be different factors that, such as a decreased level of endorphins, or they may have a predominance of C neuron stimulation. So that's just an area that excites pain, essentially, in the brain. There's an imbalance of those neuromodulation controls. So they just, they have a lot of pain firing, essentially. So these are just examples. So like I said, it's just very complex and, other factors that kind of integrate within it. Unfortunately, it becomes like a state of existence. Once again, very, very hard to treat. The cause often is actually unknown. A good example, like a lot of patients will have back pain, and you were to do scans on them, like an MRI, and you may not find much, to be honest. And it doesn't mean that you can't discount their pain. Usually there's obviously something going on there. But there's times that you can't even, it's hard to pinpoint the exact cause of it. And it doesn't typically respond to that very usual therapy. Like you can give them NSAIDs, you can try this, you can try that. And a lot of times it doesn't, it's not, it may help a little bit, but it's not going to relieve it essentially. Chronic pain can come on suddenly, obviously from an acute process and, progressively develop into chronic pain, or it can come on slowly. There's a lot of obviously disease states that contribute to chronic pain. So obviously we'll talk about these as we move through the course, but you think about things like osteoarthritis or autoimmune disorders like rheumatoid arthritis, even osteoporosis. They start to get microfractures in the spine. And, there's a lot of musculoskeletal issues that can develop and cause chronic pain. Another good example is like fibromyalgia. And once again, we'll talk about this as we move through the course. But these are usually defined as chronic, and they progress, unfortunately, sometimes can progress, but they tend to last a very, very long time, if not indefinitely. I added the image on the right because, like I mentioned, there's a lot of changes in terms of like neuromodulation with the brain in terms of chronic pain. When you think of acute pain basically starts at that peripheral area. So you have like that bottom up recognition. So you feel pain, it gets transmitted up to the brain, and then obviously you get that pain response. However, when pain becomes chronic, it's not that you lose this, you still have that, but there's more of that top-down pain, essentially, meaning that there's a lot of changes inside the brain or the central nervous system that are basically facilitating that pain response, or they lose that inhibition there. So they tend to have more of like a top-bottom approach, if that makes sense. So just an example. But response to patterns may vary with this, so they may have exacerbations where it's worse or better. But once again, there's significant behavior and psychologic changes, unfortunately, with chronic pain. And those are really important areas to assess in your patient, too. The most common, you'll come into contact with this over and over again, especially in primary care or in the outpatient setting, even in the inpatient, back pain. It's musculoskeletal pain in itself is probably one of the top reasons that patients seek out care, whether, it's an injury or a chronic issue. But back pain in itself is very common. You'll come into contact with this a lot. And it can be due to an organic problem, whether they have, degenerative disc disease. And we'll talk about these later, but just in general, this is a very common cause. Myofascial pain syndromes, a good example would be like fibromyalgia. So this is basically more of that muscular and fascia-related pain, but they tend to have very tender points on their body. And this is an example, like these are the tender areas that you would see with fibromyalgia. And when you're doing an exam, if you were to palpate over those areas, a lot of times it elicits tenderness in the patient. And fibromyalgia is very poorly understood. There's still a lot we need to know about it in terms of treatment and identification, and we really don't know the exact mechanism of how it occurs, essentially. But once again, it does have it's heavily integrated with that chronic pain response with it. Post-operative pain, you can have patients with adhesions, if they have hardware in, like if they had some kind of surgery, obviously you can have chronic pain. Cancer pain, unfortunately, is one of a very, very common or the most common cause of chronic pain that you can identify a disease with. So back pain is most common, but a lot of times we can't find that underlying cause. Where, cancer pain, obviously there's a reason there. So that's the other most common in terms of chronic. Low back pain affects up to 80% of the population, and unfortunately 5% becomes chronic. So most of the time, and it's not to say that you could have, pain for 6 months and have it not go, or, it's not going to go away. It may. It's not to say that it won't. But unfortunately, there's a certain set of population or certain set of individuals that it becomes chronic. But it's one of the most common reasons for disability and time off work. It's very, very common. And there's a lot of things in the spine that could, obviously go wrong. And we'll talk more about this as we move into musculoskeletal. But once again, you can do, x-rays or you can do imaging with MRIs, and sometimes you may not see an underlying cause there. Sometimes you'll see things that are way worse than that wouldn't correlate with what they're presenting with. Like you may see a huge herniated disc at, like upper lumbar area, and they're presenting with neck pain. Um, Not that you would image both, but you get what I mean. They can present with pain in areas that you wouldn't, expect essentially. But with, the back, and we'll talk about it later, but you can have arthritic changes here. You can have changes with those nerve roots that are coming out. You can have a herniated disc, degenerative disc disease. There's multiple things that can go wrong essentially with the back. So that's why it's very common too. This you can go ahead and take a look at and read. Essentially, it's more about, sensitizing. Essentially, it's almost like they become sensitive to, that pain response. So unfortunately, over time, sometimes too, things that wouldn't be necessarily painful are actually now capable of creating pain in that patient. So that it affects that pain threshold essentially in that patient. So you can just go ahead and read this. It's just an interesting, but very common finding that you'll see in patients that have chronic pain. Once again, I added this on there too. Chronic pain obviously has more of the central sensitization process. And they start to get these neural changes with it, or neuromodulation changes with pain. So like I said, they may be oversensitive to certain areas. Same thing like with fibromyalgia. They are very, very tender, and it doesn't take much to elicit a response on that patient. So it's just an example of it. Neuropathic pain is chronic, very commonly chronic. The only time that you would probably say it not chronic, or that you could relieve it potentially, is like if you had a patient that had an impinged nerve, in their spine, and they had surgery or some kind of intervention. But obviously neuropathic is neuropathic. It's disease of the nerves. Very common is diabetic neuropathy. I almost said nephropathy, but neuropathy. Post-herpetic neuralgia is a huge one. So after herpes zoster, a shingles infection, this is very common in the older adult, unfortunately, and post-herpetic neuralgia can be severe, and it can be life-altering for older adults. There's a high incidence of depression and actually suicide with it. That is why now we make sure that we get patients, their vaccines. Now we vaccinate against, or we give the shingles vaccine to reduce the incidence of patients getting it, because it can be very painful. And we'll talk about this with the skin, but it occurs along a nerve root. I'm sure you've seen a dermatome pattern before. Two times that you'll use this a lot is like with, spinal impingement, or if you have herniated discs, or you have, that is compressing a nerve. It'll follow those nerve roots. Same thing with like post-herpetic neuralgia or herpes zoster. Herpes zoster always presents on a nerve root. It's always one-sided. You're not going to see herpes zosters on both sides of the body. You'll see it on one. I commonly see it up here in the thorax or abdomen. Those are the two areas that I have always seen it. You can get it on the face and actually the eye, which is we'll get into later, but that can have some severe implications, obviously. But that's why I added that chart, essentially. It's usually, they complain of that paresthesia feeling, so a lot of times it's more of that burning. It's mainly burning, but sometimes you'll get that shooting or stabbing pain, and that's more of like a nerve impingement. That would be more of like you had an irritated nerve. Burning is more characteristic of like diabetic neuropathy, essentially. But it's very gnawing, it's a deep pain, essentially, and it's miserable. They don't, obviously patients are in pain from it. Sometimes there's spontaneous firing. That would be more of like a nerve impingement. Once again, you can have hyperalgesia, which is basically increased sensitization. So that's exactly what I meant by like they become very sensitive to pain, and that's how you would describe it, hyperalgesia, essentially. Allodynia, you might have heard of this before too, but this is the term we use when patients have pain from things that are not considered painful. And it's common with chronic pain. So things like touch, a hug, sometimes those things may cause pain in those patients, unfortunately. So it is, it's hard to treat. These are some other examples too that I figured I'd bring up, but you can get neuropathic pain obviously from radiation, from chemo, from chemical injuries, anything that affects that, PNS or CNS. Sympathetic pain, it's interesting, and I know we kind of talked about this before a little bit, but it can be related to things like complex regional pain syndrome. It's relatively rare, and I've practiced in orthopedics for a long time, and I've only seen it, I've seen it a handful of times, don't get me wrong, but it's not as common, and it's actually pretty rare, but they actually start to get, It's innervated with your sympathetic nervous system. They have very, very bad pain. It tends to happen after an injury. Um, I've had patients that have had it after surgery or after like a knee injury. But essentially, what happens is they get vascular changes even with it. So a lot of times they present with like this redness, swelling, and I've seen it a lot in the lower extremity, like the leg. But I've seen it. I had one patient that had it in the arm, and I had 2 or 3 that had it in the leg. Um, but they tend to get these sympathetic responses that cause vasospasm or vasomotor changes, in the tissues and all that in your vasculature. So they also present with like swelling and redness like that. If you were to see it, honestly, because look, it's unilateral on this patient, you would be concerned that there's obviously like something else, like that they had a DVT and or cellulitis really bad. Obviously that's a concern too, and it's a hard overlap there to kind of make that distinguish, differential diagnosis there. And it's obviously something you always consider. Is there a DVT or is it something else like that? So it's kind of a diagnosis of exclusion almost. Central pain can cause neuropathic pain, like I mentioned before, a tumor, an infarct, unfortunately, such as a stroke, Parkinson's disease, MS is another one that can cause central pain. Phantom limb pain, I'm sure you've heard about it, but it's relatively common. It's usually multifactorial, so there's other factors probably integrated in with this as well. But these are just examples of neuropathic pain. Okay, I'm going to go ahead and put the next one on a separate video just because of the file size. It makes it easier. So just continue to the part 2, and I'll have the rest of the lecture on there for you. Thanks.